Hello, everyone, and welcome. We opened up the meeting a little bit early, but if you are in and you can hear me, maybe give a thumbs up or put a message in the chat. We'd also like to know where our audience is coming from, so maybe put your place of residence in the chat as well. The West is representing, and now the East is representing too. Awesome. Hello, Marlene. Mhm. Great to see so many familiar names, if not faces. And glad to see we have representation from all across the country and Puerto Rico. Lovely. We are just waiting till the 2 o'clock hour. I'm going to put a link in the chat for University Summit. This is a summit put on by NCSD and ASPPH, the Association of Schools and Programs of Public Health. And this is a virtual summit for disease intervention professionals on June 24th. So if you are interested, you can click the link there and that'll take you to the event homepage where you can register to attend. So we highly recommend it. Our presenter today, Melissa, will be has a short session there, a case study on um, disease intervention and the CDI. So I know she'll do a fantastic job, and there'll be a number of other presenters, including um, DI professionals who have taken the CDI exam. Marlene says there's an echo. If we can make sure everyone has their audio muted, um, and maybe if other people could indicate whether they're having an echo. Sometimes if you hear an echo, okay, thanks, Janine. Um, good. It may be helpful for you to log in, log out, and then log back in. And we'll get started in just a couple minutes. Usually we start about 1 minute after, just to give people some time to call in if they're having any issues. Great. It seems like most of the people don't have an echo. So for those of you that may be hearing an echo, just make sure you mute yourselves. If you're calling in on the phone, make sure you mute it. And if you're still having a problem, I recommend that you log off and then log back in. Sometimes that solves the problem. All right. I think we're going to get started. It's 1 minute after the hour. Hello, and welcome to the second session in the CDI review series. My name is Melinda Salmon, and I work with NBPHE to support implementation of the CDI. I know I can speak for everyone at the National Board of Public Health Examiners when I say how excited we are to launch this series designed to support your preparation for the CDI exam. As you likely know, the series consists of 6 review sessions, one focused on each of the CDI domains. Sessions are held every Tuesday, beginning last week and continuing through July 7th at the same time each week. Today will be our second session. These sessions will provide an opportunity to review key concepts, discuss the application of knowledge, and strengthen your understanding of the content areas represented on the exam. Today's session will focus on Domain 2, Interviewing and Case Management. Before we begin, I have a few housekeeping items. This session is being recorded and will be made available following the presentation. I will be monitoring the chat throughout the session. Please feel free to submit questions related to today's content in the chat at any time. Today's presenter and I will do our best to address questions during the session as time permits. Questions regarding your specific CDI application, the exam process, scheduling, or other topics not directly related to this domain should be directed to info@nbphe.org, and I'll put that email address in the chat so you will have it. So now let's get started with our Domain 2 presentation. So this project is supported by the CDC under a cooperative agreement awarded to ASPPH and sub-awarded to NBPHE. You can see the funding opportunity number there. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by CDC or the US government. We have to say that. You probably know. We just wanted to highlight the university webpage where you can access the study materials, practice tests, additional information about the DI certification. And we also will be launching an interactive study guide very soon, which will also be available through this webpage. So now we are going into Domain 2. So let me introduce our speaker. Our speaker is Melissa Boyette. She's the Director of Partnerships at NBPHE. Melissa has 27 years of experience working in the field of disease intervention for HIV, STI, Mpox, and COVID-19, both at the national level at CDC and in health departments in Colorado and Alaska. Melissa is excited to bring her experience to her role at NBPHE, where she focuses on fostering relationships with partners to advance public health certification and support the public health workforce. Melissa also serves as a subject matter expert in disease intervention to support the development and launch of the CDI certification. She currently lives in Fort Collins, Colorado. And Melissa is really the driving force behind this, the CDI, and it's so great to have her on this project. And I'm so excited for her to do this, to make this presentation on this domain. So I'll turn it over to Melissa.
Thanks, Melinda. Yeah, so happy to be here with everyone. If you've emailed our info box, it's likely that you've heard from me or one of us here at NBPHE. And I'm super excited to bring the experience I have working in the field of disease intervention to this certification and to this presentation today. We have our work cut out for us, folks. This is a really dense domain. The interviewing and case management is a cornerstone activity for disease intervention, and it's sort of chock full of lots of principles and skills and methods and that kind of thing. So we're going to go through it section by section. I'm going to do my best to get through all of the slides without it feeling rushed, but I am, excited to bring this content to you And, feel free to ask questions along the way, or, we really do hope there's opportunities for engagement along the way as well. Um, so let's just dive in. So today we're going to be reviewing the interviewing and case management domain, which is 20% of the CDI exam. And just as a reminder for folks who might be joining this session who weren't on the last session, um, all of the content that we're presenting today comes from the CDI exam study guide. So we developed a comprehensive exam study guide. It's available on University, but we wanted to offer these sessions as a little bit, for just kind of bring it to life a little bit, talk through some of it. But there's really nothing new here that's not presented in the study guide. So if you want to return to that material or go back to it, then I recommend that you look at the study guide. And I did see a question in the chat. Melinda mentioned that we're recording these sessions. We're not sure where they're going to live. So they're either going to be posted on University or on our website. We're going to need to work with ASPPH to make that determination. Once we figure that out, we will get them posted and make sure that folks have a link to those recordings. I joke, I can't imagine you'd want to listen to me go through this twice, but if you do, we'll make sure you can get to that recording. So throughout the presentation and all of our presentations for the review series, we have examples embedded in our presentations. And the interesting thing about developing a certification is that we're kind of creating a set of standards that you may deviate from these standards in your own practice, in your own jurisdiction, based on local protocols. And so the examples that we're using in this presentation today are really for the purposes of exam preparation. They may not reflect your local procedures. We understand that. And obviously, we're going to encourage you to do what your jurisdiction and leadership are telling you to do in certain scenarios. So just kind of take these examples as learning opportunities, not policy. Okay, so here we go. The domain 2, interviewing and case management, has 16 tasks. This is the biggest domain that we have. So when you're looking at the tasks for domain 2, we're going to look at collecting and verifying relevant information to determine investigation needs for people diagnosed with or possibly exposed to infectious disease, define confidentiality and perform the investigation in a confidential manner, discuss the purposes of the disease investigation, for example, interview, test results, disease exposure, and environmental risk, making sure folks understand what our purpose is. Motivating people to participate in disease intervention services, whether it's testing, treatment, referral, isolation, quarantine, partner elicitation, et cetera. Comprehensively interview cases by using effective communication skills. There's lots of communication skills involved in the nuanced sort of the art of the interview. I think, I've been around a long time. I went to the original ISTDI in, I think, 1998. It was a 2-week interviewing boot camp. And over the decades and years, our training opportunities have shrunk and shrunk and shrunk. And now folks, maybe don't have an opportunity to really perfect those robust communication skills that really represent the art of the interview. And maybe some of you are kind of working from a form and checking boxes. And we're really going to promote these interviewing skills as a way to enhance the impact of your interviewing opportunities with the folks that you're working with. Obtain a detailed assessment of people diagnosed with or possibly exposed to infectious disease, risk histories, sexual history, drug use, incarceration, demographics, travel, all kinds of things. Elicit demographic and locating information about people exposed to or at risk of disease. Elicit information on venues or social settings where people may have been exposed to disease. We're not done yet. There's a whole other page of tasks for this domain. And again, the tasks are sort of those work activities that will be assessed on the CDI exam. So when we say domain and task, domain is that umbrella category that are represented on the exam, and the tasks are really the skills or the knowledge that will be assessed on the exam. So every question on our exam has to be tied to a domain and a task. Okay. Determine the needs and barriers related to disease intervention for people diagnosed with or possibly exposed to infectious disease. Refer people to appropriate support services. collaborate with people diagnosed with or possibly exposed to infectious disease to develop and implement an action plan, sort of the so what of the whole thing. What are you going to do with this information that we just provided to you? How are we going to get it taken care of? Verify whether people diagnosed with or possibly exposed to infectious disease followed an action plan. So again, you don't just refer and close it out. You got to really loop back and circle back and make sure that they're getting the services that they need. Perform a record search of information on people diagnosed with or at risk for infectious disease to obtain and document any relevant locating, testing, and treatment information. We don't like to go in blind. We really want to know what's happening with them. Locate and communicate with people exposed to or at risk for infectious disease. Follow up with people exposed to at risk for infectious disease to ensure testing, treatment, and other referrals, and adhere to public health principles during interviewing and case management. So these are the 16 tasks that we're going to talk about today. Throughout the presentation, you'll see a little blue box at the bottom of some slides highlighting what task that particular slide pertains to. So again, really trying to tie the content back to the exam, back to those exam domains. I'm just giving you sort of subliminal messages along the way. So look for those little blue boxes to kind of highlight the tasks on the exam. Okay, so let's get to it. Today, we're going to examine the key components of interviewing and case management for people diagnosed with or potentially exposed to infectious disease. Effective interviewing and case management play a crucial role in disease intervention, ensuring that individuals affected by the disease receive appropriate support, testing, treatment, and prevention services. So our first of 7 sections is the overview of interviewing and case management. So case management is defined by the Centers for Disease Control and Prevention as the systematic pursuit, documentation, and analysis of the medical and epidemiologic information about a case to develop a plan for disease intervention or other treatment and prevention measures, depending on the type, stage, and severity of infection and disease. So that's kind of, that's what we do when we're managing our cases, where really the whole process is encompassing case management. There are 6 steps in the case management process. The steps in the case management process include interviewing activities, referral of people who were identified as contacts or partners. And the 6 steps in the process are: step 1 is that pre-interview analysis. This was what we talked about in the last session, really kind of doing all that legwork on the front end so that your investigation is efficient and rolls out nice and smooth. Then we have our original interview session. That's kind of that first interview with someone. Then we'll have that post-interview analysis. This step we cover in detail also in chapter 1, the planning and case analysis, kind of looking for those gaps in your investigation. Then we have our referral of people who were exposed or who are at risk. And then we do our cluster or re-interviews. So maybe we need to visit back with our original index case because there's a gap, or, we kind of get all of the test results in and we don't find a potential source. We know there's somebody missing. We might do a re-interview. Or maybe we have a particularly chatty contact who wants to kind of open up and provide us information about a network of people that would benefit from testing. So that would be our step 5. And then we have case closure, which is step 6. So case investigation, I think the first time I really heard this term used in common vernacular was during the COVID pandemic. This is where case investigation and contact tracing were front and center. We were very public about this process. And this is sort of, familiar to everyone now as the process of case investigation, which is the process of interviewing people with confirmed and probable diagnoses of an infectious disease and working with them to, there's kind of a lot of goals, right? We want to assure that people know about their positive test or their diagnosis. We need to inform them. Then we discuss health information, including symptoms, treatment history, and other related health conditions. If it's relevant, we'll encourage symptom monitoring and refer for relevant medical treatment as appropriate. So sometimes it's a wait and see kind of thing, like Mpox. We were like, well, you can go get a vaccine and then look for symptoms. And then we might, then we identify people who may have been exposed to the infectious disease based on the mode of transmission. So again, we're working really hard in this CDI review series to be as disease agnostic as possible, meaning that we're not talking about a particular disease. This isn't just STIs or just foodborne. So some of our terminology is a little bit generic, and that's on purpose. But you all know the mode of transmission for the infections that you focus on. And then we need to refer people to other medical or supportive services. Sometimes in order to focus on this new thing that suddenly they're faced with, they may need to figure out something else in order to divert their attention. It may be transportation. It may be that they don't have, a safe place to quarantine, if they're unhoused and they may need support to be able to quarantine safely. So those are things that we also have to consider. Then we have, I think of this as like the A side or the X side and the Y side of an algebra equation. We have our case investigation, and then we have our contact tracing, two sides of a coin. Contact tracing is a core public health practice used to identify and support individuals who may have been exposed to an infectious disease. Now, for STIs and HIV, we have a specialized approach known as partner services, and that focuses on sexual and needle sharing exposures, but also ensuring access to other supportive services. So we may be doing some other things in the STI HIV realm that aren't common practice in other disease etiologies. Either way, for both strategies, DI professionals work with individuals to notify them of their potential exposure, discuss health information, again, including like potential symptoms, identifying if they've already had symptoms or making sure they know what symptoms to watch out for, and any other related health conditions they may have, referring for appropriate testing, vaccination, or treatment, whatever is indicated, and emphasizing the importance of following public health recommendations, whatever they might be, for whatever disease it is, to prevent transmission while awaiting their test results, encouraging symptom monitoring, and outlining a plan to seek medical services if symptoms develop. And this is for diseases with no prophylactic treatment. Providing case management services to assess needs and refer individuals to other supportive services such as food, housing, transportation, primary medical care, mental health services, and substance abuse treatment. And then identifying others with similar risk factors or exposures who would benefit from testing. So folks who attended the same event or folks who all kind of, shot up together at a party or whatever it might be. The purpose of disease investigation, disease investigation is a crucial part of public health, helping to detect, control, and prevent the spread of infections early on. To support this process, a case investigation interview for diseases of interest can be conducted to understand how diseases spread, identify their source, and take action to protect people. I always joke that without folks like us, our data friends wouldn't have all that juicy data to work with and to be able to describe and characterize our infectious disease threats. It's us that goes out and builds rapport and talks to people and engages them to get all of those juicy details and put them into data systems so that they can be analyzed to describe our epidemiology. Ensuring that people infected with or exposed to an infection understand the purpose of the interview is critical for effective engagement. They have to know what you're doing there. Otherwise, if you just like lay into them with a bazillion questions, you're probably going to lose them. Helping the person understand that by participating in the interview process, they're contributing to stopping the spread of the disease within their network and community can motivate them to take part. The interviewing process begins with speaking to people diagnosed with or exposed to an infectious disease. By asking about their health history, social interactions, and potential exposures, DI professionals can trace how the disease is spreading and work to prevent further transmission by identifying other people who were potentially exposed. Laboratory tests and clinical assessments, like blood tests or physical examinations, help confirm diagnoses and rule out other possible conditions. So this is obviously a critical step to differentiate from one disease to the next. Environmental factors also play a big role. Contaminated water, air quality, close contact with infected individuals can all contribute to the spread. Overall, disease investigation enables health professionals to detect outbreaks promptly, contain infections, and provide the appropriate care to minimize harm. This process keeps communities safer and reduces the overall burden of disease. And here you can see that this slide kind of tags back to task 3 there at the bottom. We made it through section 1, only 6 more to go. We can do it. These are the key words for section 1. If you're interested in learning more about our keywords, if interviewing is really new to you, maybe you work on a mobile health unit and you do lots of testing and engagement and data collection, but as soon as they test positive, you hand them off to a public health department staff. You might really want to study the interviewing chapter. If that's the case, there are some flashcards for each of the domains on the university website. So look for those flashcards there if you're interested in practicing more with our keywords. Okay, so now we're going to move into the interviewing process, interviewing people with infectious disease. When a person is diagnosed with an infectious disease on the National Notifiable Conditions List, the healthcare provider and laboratory are obligated to report the infection to a presiding public health authority. These are examples of the information that should be included on the case report. I say should be, like in my dreams, it would always have an address, a phone number. We all know that sometimes this information is missing, but between the two sources, we hope to capture most of it so we don't have so many gaps to fill. The information is used to determine whether the reported case will be assigned to a disease intervention professional for a disease investigation interview based on your local priorities. So, you may have some sort of prioritization grid where, like I know for syphilis, if it's a low titer RPR in a very elderly person, that one might be automatically closed out, for example. And there may be other examples you can think of. The objective of the interview is to prevent further spread of disease through the prompt identification and examination of all people who were exposed to the infectious disease, including contacts or partners and social contacts. I always say, if you're not getting names, there's no intervention happening. So our job is not surveillance. We aren't surveillance people. The data collection is a byproduct of the intervention that we're doing with folks. The interview is designed to ensure that the person being interviewed understands the seriousness of the disease and motivate them to cooperate with infectious disease control efforts. It's also designed to increase the likelihood that all at-risk people are identified so they can be notified of their exposure and referred for appropriate examination, testing, and medical intervention, including treatment. DI professionals should approach the interview and subsequent communications using person-centered counseling techniques to develop a personalized risk reduction plan tailored to each individual's needs. So I worked with a guy when I was up in Alaska, and he had been a DIS for a long time in another state and for a long time in Alaska. He was a very old school dude. He wore the same color shirt every day. We never knew if it was the same shirt or if he had 7 of those shirts, not sure. Every interview was exactly the same. It was in his mind sort of scripted. And, he sort of failed to follow that person-centered model of really tailoring the interaction to the person on the other end of the phone or the person in front of you. And I could hear on the phone very often resistance building where people didn't really, they don't have the script, right? They don't know how they're supposed to respond. So the more tailored and person-centered you can be in your approach to each individual person, the more successful your interviews will be for sure. Now, there are 3 types of interviews used to elicit information from people diagnosed with an infectious disease. And I will say some of this terminology really is grounded in principles of STI and HIV interviewing, but I think it works for all diseases. But some of these may be new terms if you're outside of the STI HIV world. First, we have our original interview. The original interview is the first interview with a person diagnosed with an infection, sometimes called the original patient or the index case, depends on where you're at in which field you're in. The original interview should occur promptly to begin the process of identifying people with potential exposure. Other critical data elements, such as risk factors, treatment, and travel history, are also gathered during the original interview. So this is your first big shot, right? This is our best opportunity to build rapport, engage with folks, and obtain the information we need to stop the spread of the infection. Then we have the cluster interview. A cluster interview is an interview with an uninfected person conducted to gather information about previously unnamed partners of people with an infectious disease and individuals who may be at risk of the infection who would benefit from testing. Clustering is also an interviewing technique that can be used during an interview with a person diagnosed with an infection to identify others who may benefit from intervention, but they're not contacts or partners. And that's based on shared risk behaviors or potential exposures. So clustering is sort of like that who else do you know that might benefit from testing? Like who else do you know that's hanging out at this place, or who else do you know that's using needles, even if you've never shared needles with them? So clustering is a way to expand, kind of zoom out a little bit, expand our focus, and identify additional potential folks who are at risk. And then we have our re-interview. I always think of it as like clean up on aisle 9. This is our opportunity to get those things that we may have forgotten to get, or gaps that we identify when we do that post-interview analysis. So a re-interview is a subsequent interview of the person with an infectious disease to gather additional information necessary for case analysis and to identify or get further locating information on named partners, contacts, or social contacts. So this is your opportunity to say, hey, that phone number you gave me didn't work. Can we check on that? Or, if like I said, if you got back, you notified all the contacts that were named, you got back your results, and you don't find your likely source, you would map it back out and be like, I think we're missing somebody, and this is your opportunity to revisit and kind of gently highlight for people that there's an obvious gap. Sort of say like, hey, somebody's missing, rather than like, who else can you think of, to really be pointed and maximize that re-interview. We have several goals for the interview process. A successful interview enables the collection of critical information about a person with an infectious disease and other people who may have been exposed, while providing support, referrals, and answering questions. And I'll tell you, this is a real balancing act. You know, our role is really tricky because the crux of a lot of that surveillance data, they rely on us to gather that data, but we should really never compromise the interview process, the opportunity to build rapport and be person-centered with folks that we're talking to because we're trying to get data. So it's a balancing act for us. The data is important, but if we don't build that relationship, not only will we not get the data, but we won't prevent the spread of disease. And so it's again that the art of the interview is balancing those two needs. The goals of the interview are to refer the person with infectious disease for necessary treatment as appropriate, whatever the treatment might be. It might be a vaccine, it might be quarantine, it might be whatever. Gather important data elements about their exposure history and risk factors to understand how infectious diseases are spreading in the community. Assess symptom history and previous treatment. Again, like with some diseases, they may have had incidental antibiotics, for example. I know with syphilis, say they were treated for bronchitis 3 weeks ago, that really could interrupt the way that symptoms unfold for them. So we would want to know if there's incidental antibiotics at play. Emphasize the importance of taking precautions to prevent further transmission. So again, working with them to kind of come up with a plan to prevent transmission until they're no longer infectious, whether that's time or treatment or whatever the preventative measure is. Obtain the names and location information of other people who may have been exposed and places, events, and gatherings where transmission may have occurred. So we saw this a lot with COVID. We did a lot of venue-based contact tracing for COVID, where we were looking at weddings, conferences, school events. So rather than person by person, we could kind of capture folks in venues. And then identify opportunities to provide testing and prevention services to individuals and communities at risk. So this last one's kind of key. This is where we have that intuition, right? I think we develop over time. I always say my spidey senses tingle, where I can kind of tell if I've had my third case in the same motel that's like a pay by the day kind of motel, maybe it's time to go and offer a screening in that motel. And so that's that higher level intuition and gut feeling that you have. Maybe you don't just go with your gut, you look at the data, you talk to your colleagues, you talk to your supervisor and say, has anybody else had a case in this hotel? Because I've been over there 3 times. And then you offer that next level intervention. So now we have some tips for successful interviews. Clear messaging about how disease investigation works is crucial. The why. Why are you calling? Simply introducing yourself. Hi, my name is Melissa. I'm with the Department of Health, and I need to talk to you about this infection. May not really do it for folks. They might need to hear from you what our role is, what's the point of all of this? We're really working to prevent you from getting reinfected and to protect your community, your friends, your colleagues, your family member, however the disease is transmitted, to give them that better sense that they're participating in something of value. Building rapport and trust through the use of open-ended questions, active listening techniques, and motivational interviewing is essential for addressing concerns, providing support, and gathering accurate information to inform the next steps of the disease investigation. And we'll talk about all of those skills later. This can help address concerns of the person being interviewed. So maybe they're worried about privacy or confidentiality, or maybe they're like freaking out and they don't know what they're going to do with this information that you've given them. They might have some real barriers to accessing care. Maybe they don't have insurance and they don't know how to get care. So this all working with those concerns fosters cooperation in the process. Now we'll talk about calculating the interview period. This was discussed during domain 1, but we're going to revisit it here as well because it is really important to the interview process. So before conducting an interview, the DI professional must calculate the interview period to establish a timeline for the interview. And again, this is something you do on the front end and maybe adjust in real time. As you gather more information during the interview, it may shift your interview period. They may tell you about a symptom that wasn't in the EHR, it wasn't in their medical record, and you can kind of adjust it from there. The interview period includes both the incubation period and the infectious period and helps to identify both the source, so sort of our back contact tracing, and people who are potentially exposed, so that forward tracing. The incubation period is the time from the initial exposure to the development of disease. And this incubation period varies depending on the infectious disease of interest. Some of them have really long incubation periods, some of them are shorter. And the DI professional should be aware of the incubation period for all of the diseases that they investigate. Obviously, I'm sure you know that stuff. Then we have our infectious period. This is the time frame during which a person with an infectious disease can potentially expose other people. So this is that onward transmission time frame. And this varies depending on the disease. The DI professional should be aware of the infectious period for all the diseases they investigate. So it's sort of that forward and backwards looking. An assessment of the person's symptoms and testing history helps identify the dates of their infectious period, allowing for the identification of people who may have been exposed, as well as the incubation period, which can help identify the potential source of infection. Sometimes folks don't have symptoms. What do you do then? Then you kind of have your timeline based on the date of the interview. So sometimes we don't have the luxury of a big fat juicy symptom that's obvious, and we need to work with the time frame of kind of the date of the interview or the date of treatment. So now we're going to do an example. This is a measles example. This little baby made me so sad when I found this picture, but anyway. So let's talk through an example of how to calculate the interview period. In this example, so we have our incubation period, typically for measles would be 10 to 14 days. And it would be kind of tempting to go with that 10 to 14 day period. But in order to ensure that you identify any potential source of infection, the best practice is to use the outside range of the incubation period to establish the interview period. So you would go back that full 21 days. You would also need to include the full range of time that the child will be infectious, which would be another day after the day of diagnosis. Because for this one, we have this baby had a rash. So let's go to the next little thing here. A child presents to their healthcare provider with a fever, cough, and rash that began 3 days ago. The child is diagnosed with measles and the family is instructed to isolate the child. What is the interview period for this investigation? So for this one, we're looking at the 3 days since the rash, and then we have our 21-day outside incubation period. So the start date would be that 3 days of rash plus the full 21-day incubation period. So the start date of the interview would be 24 days prior. So if you want to know, like, where did this kid get measles, you would start 24 days before the interview date. And then that time frame will help to identify the potential source of infection. Now, the end date, when do we end the interview? For measles, which, again, there's no disease-specific information on the exam, so this is just an exercise in like what to consider when you're calculating an interview period, which is on the exam. But for the end date for this one, we would include that 4 days after the rash appeared because the baby may have potential contacts. It's not like this is a college kid. This kid needs full-time care. So the caregiver, family members who can't avoid contact with the child would still be getting exposed and could potentially still be infected even after the interview and even after the disease is identified. So that would be the all-encompassing kind of how to think through your interview period. All right. We're almost done with section 2. The interview format. So this interview format, again, this was grounded in sort of STI interviewing principles, but I think the format really is helpful for any disease process. So it can be beneficial for DI professionals to follow a standard format when conducting interviews with people diagnosed with or exposed to infectious disease. The interview format below is one example of a general framework that allows the interviewee to understand their diagnosis and have their concerns addressed, while also focusing on the important steps of eliciting partners and contacts. So this format can be kind of applied no matter what disease you're doing. First, you have your introduction, and this is your sales pitch, right? This is where you sort of compel folks to get on board. You state your purpose and your role. You make sure that they understand that it's confidential and even that you're there to help them and their people in their network. Then you have the assessment of a person diagnosed with an infectious disease. So you resolve their concerns, like what were you most worried about when you heard that you have XYZ? You get that social history, talk to them about their medical history, and ensure that they understand the disease, that disease comprehension. Then we do the disease intervention portion of the interview where we're talking about eliciting contacts and getting, partners' contacts identified, and then discussing how to prevent transmission to others and developing that risk reduction plan. Sometimes this is like a behavioral discussion around reducing your risk for acquiring HIV, for example. You might talk with them about PrEP or about altering some of their safer sex behaviors. Or it could be a shorter term risk of like, what are you going to do until you stop coughing and no longer have a fever? So that risk reduction plan can be tailored. And then you have the conclusion. I always like to wrap it up and make sure that folks know that it's over. Have you ever been left sitting in a clinic room at the doctor and you don't know if you're done yet? And you're like, can I go? We don't want that feeling. We want them to really know that the process has completed. Thank you so much for talking with me today. If you have any questions, please reach out. I may contact you to, there may be things we didn't talk about, so don't be surprised if you hear from me again, etc. Okay, so these are our key words for section 2. This was all of our juicy interviewing stuff. And again, those can be explored using the flashcards on University. I think I'm going to pause, Melinda, and just make sure if there's any questions or anything in the chat that you think is something I should address before we move on, since we've got so much content to mow through here. Okay. Okay, looks like we're good on the chat. So I'm going to keep on trucking here. This section, we're going to talk about identifying people exposed to infectious disease. So this is our partner contact. This is what puts the I in intervention, right? That's not a real saying, but this is the whole point. This is what we really are working to do, is stop the spread of disease by identifying people who've been exposed. So let's talk about that. A key strategy to reduce infectious disease transmission is to conduct interviews with people diagnosed with an infectious disease to identify individuals, locations, events, and activities where exposure may have occurred, thus facilitating prompt intervention for those who may have been exposed. So again, maybe it's talking about a wedding that they attended. Maybe it's talking about, an actual sexual partner or someone that they were sharing needles with, or a household exposure. I worked in Alaska for a long time, and we had really, pretty high rates of tuberculosis, and we had a lot of household contact, shelter contact, that kind of thing. So it just depends on the disease. But we focus on those opportunities for identification of additional infection. Depending on the disease of interest, several factors can influence exposure risk, including the type of exposure, proximity, like literal closeness, duration of exposure, environmental factors, vaccination status, and prior infection history. Prevention of infectious diseases is at the heart of public health disease investigation and typically involves interviews and notifications and referrals of people who are exposed to an infectious disease. Being aware of their exposure is key to the person's awareness and is necessary for them to understand the need for examination, testing, and treatment with appropriate medical intervention. During notification and referral, DI professionals also have the opportunity to discuss the individual's future prevention and behavioral risk reduction techniques. The interview is also designed to increase the likelihood that all people who were potentially exposed, for example, sex and needle sharing partners, contacts, social contacts, are identified so they can be referred for examination, testing, and treatment. The DI professional should also provide person-centered counseling to develop a personalized risk reduction plan. Disease intervention occurs when someone who has been exposed to an infectious disease is tested and, if appropriately, promptly treated, regardless of test results, to prevent the development of disease, onward transmission, and complications. Ideally, our process is happening real time enough that we're actually aborting the development of disease. We are interrupting disease development. I remember early in the COVID pandemic, I was up in Alaska and everything's slow up there, far away. Testing was very far away. And I was doing case investigation and contact tracing for COVID, and I would get test results on someone tested 9 days ago. And I was like, really? Like, what's the point of that? They have 1 day left of isolation. Their contacts are probably all already symptomatic, already spreading COVID everywhere. So that real time, that timeliness, the sense of urgency is where we find that we have the best opportunity to interrupt transmission, not just catalog what has already occurred. Prophylactic treatment can be initiated for individuals who have been exposed to bacterial infection while it's incubating within their body. Prophylactic treatment can be provided by a healthcare provider in combination with examination and testing or via expedited partner therapy, or EPT. EPT is the practice of treating sex partners of people diagnosed with gonorrhea or chlamydia, for example, by providing medication or a prescription to the person diagnosed with an infectious disease to deliver to their partners without a clinical encounter. There's also models of EPT where folks can go in to a pharmacy. We did that in Alaska. We had doses of EPT at a pharmacy, and people could be referred into the pharmacy to receive that treatment. I've seen this used, preventative treatment being provided. The case study that I'm presenting at the University Summit was all focused around a meningitis outbreak, and we were field treating folks for meningitis. So it's not exclusive to STIs, but I think it was that the term was coined and it was originally pioneered in the world of chlamydia and gonorrhea treatment before we went to strictly injectable gonorrhea treatment. That complicated things. But EPT is a really good strategy for those kind of high volume infections that can't always be investigated on the individual level. Disease intervention is achieved at 3 levels of prevention. This is important. So we have primary prevention, which prevents the development of disease in an exposed partner or contact by administering preventative treatment. So that primary prevention, again, they never have a chance to develop that disease. Boom, done. Then we have secondary prevention, and this is where we administer treatment to people that are infected, thus stopping the spread to others. So this is preventing that onward transmission. We didn't quite get to them in time, but maybe we can prevent onward transmission or reinfection of the person originally diagnosed. Then we have our tertiary prevention, and this is to prevent the development of serious complications in people diagnosed with infectious disease. So I know for a while we were pretty focused on infertility prevention, and in Alaska we actually did investigate cases of chlamydia, and really the goal there was kind of that tertiary prevention, looking at preventing infertility and complications, miscarriage, etc. So that was, maybe the chlamydia by itself doesn't seem like such a big whoop, but that tertiary prevention, infertility, etc., was at that time we had the resources to be able to do that. Elicitation of people exposed to an infection is the process of obtaining key data elements that aid in identifying and locating people in need of intervention services such as testing, treatment, or vaccination. Important details to collect include identifying information, including their name, nickname or street name, screen name on social media, dating apps, etc., their handle, date of birth, complete or partial, and or their age. So maybe your person, like, I mean, let's be honest, like the likelihood that everybody's going to know everybody's date of birth is pretty slim, but you might be able to kind of work with them around like, when's the last time you celebrated their birthday? What time of year was it? Was it in the summer? Did you have a barbecue? What did you do for their birthday? Trying to jog their memory so that you can narrow it down, which may help your record search later. Um, Address, alternative address, or location where they stay. So there's like their address, and then there's like where they are. And making sure that you know both of those, it can be really important. Even including things like Hangouts, their place of work, their email, their social media handles, any way of locating that person. Then we have the physical description, such as height, weight, build, hair and eye color, skin tone, tattoos, piercings, hairstyle, manner of dress, doesn't matter, like whatever it is, it's really important to elicit that level of detail. And then last but not least, certainly super important is your exposure dates. If you don't get exposure dates, you don't know what they need. You don't know if they're outside of the incubation period and they only need testing. Maybe they need preventative treatment. We don't know if we don't know when the exposure took place. Um, so I have a little story. I've been doing this a long time. I've been interviewing people my whole life, basically. And I did an interview and I asked this woman, like, if I walked into a room, how would I know it was him and not somebody that looks like him? She was like, well, he has this really smashed nose. Like it's not really smashed, but that's just how it was made. Like he just has really smashed, and he has this big forehead, and he kind of looks like Frankenstein. That's what she said. I was like, okay. So I couldn't get him to call me back, couldn't get him to respond to any of my attempts to reach him, but I saw that he had a court date. So I showed up at the courthouse. And I walked in, and based on that physical description and a few other details she gave me like really good, because I asked, right? We got to ask to get the information. And based on that physical description, I walked into the courthouse and I sat right next to him. And I leaned over and I said, hey, are you so and so? He looked at me and was like, busted. So the better your physical description, the better you're going to be able to identify and find folks when it gets hard. Now, obviously, if you have like a phone number and they're super cooperative, slam dunk, great, good for you. But in my line of work, I rarely had that luxury. Okay, so now we're going to practice this. We have this example of this charming dude. And I thought it would be fun for you all to kind of practice creating some questions, some open-ended questions, um, to kind of how would we get a good description of this person? What types of questions would you ask that would give you good information about this person and what they look like? So we're eliciting physical description um, on this dude, and we're going to use it. We're going to do a poll. We think we figured out the poll. So I'm going to ask Melinda to launch the poll. And if it's launched, I can't see it. So Melinda, I'll have you keep an eye on it.
Yeah, I'm having trouble. Let me say launch. If I'm having trouble with my mouse for some reason.
Oh, okay.
Okay, hold on.
Hold on.
I don't know why it went crazy.
Can you use your little touchpad?
Did that, can people see it now?
No. Hmm. These
I
polls are
don't,
killing us, yeah.
I'm so sorry. I'm not quite sure what happened here.
Oops. Okay. I wonder. He is happy. I know he looks happy, right? I really liked this picture when I found it. I
No,
was
it
like,
says
hey.
fail. You know what, Melissa, do you want to try to go in? I'm going to try to leave and come back in.
Sure.
But if you
Okay.
go under polls and quizzes, maybe, yeah, I'm not sure what happened for
Yeah,
me.
let me see. Um, I think because I'm not, the main person. Oh, Lordy, y'all. Okay, so
Well, we could have people put in the chat the
yeah, for now.
questions.
Yes, for now, because I don't actually see the polls and quizzes prompt on mine, Melinda.
Okay. All right. So if people could just put in the chat,
Yeah, so put in the chat some
open-ended
questions.
questions that you might have. What the
And I have a few examples too, but I'll give you a little time to formulate some things that you might ask to get to this person so that if you walked into the courthouse, you could sit down and sit next to this guy. Am I still sharing my slides? Did I just totally goof up? I don't think I'm sharing.
Nope, your slides are still showing.
Oh, are they? Okay.
Are we getting any questions in the chat? I'm trying to solve my problem here.
Let's see what we got. Oh, now folks are saying the slides are not showing.
Really? Um, okay.
Let's fix that so you can all see his cute face. Sorry, this is the thing is like, this is our weakness.
I'm trying to log out of multiple things so I
Oh, they're
can.
back. Okay, great. So yeah, I see some good ones. I want to highlight a pitfall. We haven't talked about open-ended questions yet, but any of the like do you questions are actually technically closed-ended. So some of there's great examples in the chat. Some of the ones I had are how old is he? What's his approximate build, height, and weight? Describe his skin tone to me. If I saw him in a crowd, how would I know it was him? What other distinguishing features does he have? So again, focusing on those open-ended questions, allowing them that latitude to kind of give you a nice description. Hopefully we would get, I did have another contact was named to me and I was like, if I met him in a public space, how would I know it was him? And she was like, he's always wearing his Yankees hat. So when I went and did a field visit, I met him in the parking lot of a grocery store and by golly, he had that Yankees hat and he was sitting on the hood of his car and I knew he was my guy. So, yeah, the freckles are distinguishing. So how would we get to the freckles? Like, you could ask a question like, what really jumps out at you when you first look at him? Something like that to give you those nuances. Because I'll tell you, if you get like, he's got black hair, brown eyes, 5'10", medium build, turns out that's like everybody. So we got to get deeper than that to really be able to find our right person. If we have, maybe you have potentially two people that you're trying to figure out, like, is this the guy or is this the guy? Similar age, similar build, whatnot. But you see a picture on social media and you're like, that's got to be him. Look at those freckles. Then you would be able to find your person. I like this. Does he remind you of anyone famous? Yeah. People say I look like Patricia Arquette. I don't see it, but maybe someone would, if they named me, they would say she kind of looks like Patricia Arquette. All right, so now we're going to do this again, and we're going to use the chat again until we figure out what's happening with the Melinda's access here. So this one is a location, and what we're looking for here is like if you had to do a field visit, and you were going to try to find this apartment building and you didn't have a physical address, what would you ask to get a good description of this apartment building? And while you're marinating, I'll tell my story. I was doing field work with someone who was pretty new to disease intervention, and he had done a preliminary interview in a clinic setting. He was our HIV outreach guy, and I was like, let's go out in the field and find this person together. So he had gotten cross streets. It was an apartment. Um, that was kind of it. It was 12 degrees. This was in Alaska. Ice everywhere. We both had our yak tracks on, blowing, cold. It's dark. We get to the area where he was directed during his interview, and there were literally 6 apartment buildings. And I looked at him and I said, please tell me that you asked the color of the building. And he was like, no. Because there was one that was like Smurf blue. I was like, is it the blue one? He said, I have no idea. So we had to tromp around all 6 of these apartment buildings in 12-degree weather and try to figure out which one was the right one. And he never did that again. It was a one-time lesson for him. He always got me the best descriptions after that. So we're looking at, like, how would you describe the building? How many floors does it have? One that I like is, again, like what other businesses are around there? What color is the building? What floor does the person live on? And then I like to ask, if I'm standing in front of the building, what would I see? To get a real description. So again, we've got cross streets. We could, they could say that it's kind of a beige brick building. There are balconies and fire escapes on the outside. There's a grocery store at the bottom level, but we have to ask those questions to set them up to provide that information to us. What's across the street from the apartments? I love that. Yes, getting yourself some landmarks if you really literally have to go out in the field and find this place. Um, what type of plants are around there, distinct identifiers for the building. Yeah, so now you're getting kind of the idea of how we kind of put this into practice. So yeah, so let's kind of keep going. That was fun. Um, Now, let's talk about some of the terminology here because we are talking about multiple different kinds of diseases around the CDI. So we have various terms used to describe people who have been exposed to an infectious disease. In STI control, direct contacts are called sex partners. In TB or measles, they might be used the term close contacts. And then for HIV or hepatitis C and sometimes Hep B, the term could be a sex partner or a needle sharing partner. So if there's, the risk of needle sharing involved, then we would call them a needle sharing partner. And then in STI control, we have 3 categories of elicited contacts. And this is a little bit nuanced for folks that aren't in STI, so hang with me. So we have the partner. This is a sex partner or a close contact, a person named as direct contact with the infected person. And those can be divided into 3 groups. The person has had sex or close contact with the person with infectious disease. They've shared needles with the person with an infectious disease, or they've done both. So maybe they're a sex partner and a needle sharing partner. Then we have our social contacts. This, for those of you that have been around the block, like me, we used to call them suspects. That's not a term that's in use anymore. These are social contacts, which are people who, like, an index case might name as someone who's not a direct partner, but they either have similar symptoms. So it might be like, my buddy had this same rash 3 weeks ago. Do you think he might have been like he might have it too? So that's someone with symptoms, and then someone that has a sex partner in common, right? So this is like, I didn't have sex with him, but my friend had sex with him. So, we might ask an index case, who else do you know that had sex with this guy? And then someone that just sort of might be at risk, but doesn't fit into the other 2 categories. So maybe it's like, they're like, well, I mean, I'm really worried about him. He's always putting himself out there. I don't think he uses condoms. Like, I've never been with him, but I just think he's probably needs to be tested. So we have our close contacts, partners, social contacts, and then associates are those folks who are named by someone who's not infected. So say I'm doing an HIV interview, I go out, I test a contact and they're negative, but I do a cluster interview and I ask them, like, who else do you know that might be at risk of HIV? Who else should I offer testing to? Then those folks that they name would be called associates because they're not direct contacts. Ooh, okay. During the interview, the DI professional works with the person with an infection to determine the best referral method for their contacts. There are 3 basic types of referrals for people identified as a contact or partner exposed to an infection. So first we have provider referral. So when the health department staff notifies people exposed to an infectious disease, including contacts, partners, social contacts, and refers them in for an exam, testing, or treatment. So this is where we sort of get consent from the person being interviewed. We get all the information. We take full responsibility to confidentially notify and locate all those folks that need to be notified. The provider referral ensures that the person with the infection can maintain their privacy and confidentiality while ensuring that those exposed are notified. So, the research is pretty clear that this is actually a very highly effective method for notifying contacts. Then we have self-referral, and this is referral by the person who has the infectious disease. When the person with the infection takes full responsibility to notify their own partners or contacts of the exposure and refer them in for exam, testing, and treatment. The DI professional should provide guidance on how to notify partners and contacts. You can even do a little role playing. Let's pretend I'm the person and you're going to notify me. What will you say? Where the person can receive services. So again, it's not just like, hey, you should probably get checked. I have something. Like that's really not a good substitute for what we do. So we want to arm them with all the same kind of tools that we would use to make sure they have a clear idea of where folks can get tested and treated. And also, like, there's some anonymous websites that can be used for notification of partners. And then we have the contract referral. This is kind of where provider referral and self-referral had a baby, and we have contract referral. So this is a hybrid method where the provider, the DI professional, negotiates a time frame. So we say, like, I'm going to give you 2 days to let your girlfriend know, and then I'm going to follow up with her, and we get all of her information. And you can't even check back with your index case and be like, hey, did you have a chance to tell your girlfriend before you contact them? But this way, they kind of have ownership over that referral process. I mean, it might be someone really close to them and special to them that they want to tell them themselves, but they just don't want to deal with all of the like referral piece. So we can kind of come in and do that next steps and make sure that the person gets everything they need. Okay, let's see. Okay, so it looks like Melinda's back. I'm just checking. Okay. So identifying, locating, and informing people at risk of infectious diseases is key to reducing transmission, preventing complications, and preventing outbreaks. DI professionals identify contacts, sexual partners, drug sharing partners, and social contacts to provide timely testing, treatment, and referral to appropriate medical and supportive services. Timely notification of people exposed to an infection reduces transmission and prevents complications. DI professionals use various methods to reach individuals, such as digital tools like apps, texts, websites, social media for quick communication. Field-based methods like field visits and outreach, which is going to be discussed more in domain 3. Traditional methods like emails, letters, phone calls for those with limited tech access. And by adapting communication methods and tailoring outreach, DI professionals ensure interventions are effective, inclusive, and accessible, reducing disease spread and improving community health. Again, so like, if you've got a younger person exposed to syphilis, you might go through a mobile app. If you've got, an 80-year-old who, was exposed to an infection in a nursing home, probably not be the best route to go through to use digital technologies. So you just have to tailor your method to the people that you're looking for. And whatever really is the most timely. Again, that sense of urgency, timeliness is really critical. Once a person is identified as a contact or a partner, the DI professional should conduct a record search to determine whether there's existing documentation or prior case history for that individual. So just because you got a name doesn't mean that they don't necessarily already know that they're infected. They could be the source, and maybe they were diagnosed 3 weeks ago, and you can save yourself a whole rigmarole just by looking that up. The record search should include a review of previous lab reports, case investigations, interviews, or notifications. Maybe it's someone that was notified a month ago and never went in. Making sure to kind of search through that history is really helpful. This step is essential as the individual may not require notification if they've been tested previously or treated. Similarly, when partial information is provided about an exposed person, the DI professional may need to conduct a record search to identify or locate that person. So again, maybe you're trying to match up a partial description with somebody in a data system. Record searches may include accessing a variety of data systems, including but not limited to the internet. Google search can tell you a lot. Search engines, regional health information organizations, those like HIA exchanges, social media platforms, public record databases, again, like court records, correctional databases, et cetera. Post office verification. This is pretty old school. We used to do these post office verification forms where we would request verification from the post office if the person still resides at the address. Local school enrollment logs, jail rosters or inmate census. I remember we used to have to call the jail and make sure they weren't in jail before we could close it out years ago. Federal Bureau of Prisons or inmate locators, any kind of that public inmate locator databases, and then other health department programs and sources. It may be that it's somebody that has interacted with your health department for another purpose, for another disease or something, and they've got more recent info. And then we have our people finder sites such as LexisNexis. LexisNexis is awesome, but it gives you like everything since they were born. So it can be tricky because it almost buries you in so many addresses, you're not sure where to start. But record searches can provide additional information about an individual's demographic information, medical and social history, marital status, living conditions, and other factors that affect healthcare access. Obtaining this information before an interview or notification may enhance the DI professional's interview or notification strategy. So sometimes it's helpful to know who they live with. Like, are you going to come across a partner or mom or a roommate or, kind of know what you're walking into? Are there previous interactions with law enforcement from that address? Is it going to be a safe situation? The record search can also prepare the DI professional for what they may encounter during a field visit, such as a third-party contact, pets, or other potential safety concerns. Record search results should be fully documented on the interview or field record or in other data systems. So remember what we said in the first domain, if it's not documented, it's not done. And if you win the lottery and somebody has to pick up your cases and keep working them, are they going to know what record searches you did and be able to not have to redo all that work? So Internet Partner Services is the practice of utilizing technologies such as the internet, social networking sites, email, instant messaging, mobile devices, mobile applications, and texting to locate people identified as a partner or contact. While IPS is most often used and associated with STI/HIV case management related to dating sites or apps, it may also be adapted for use in other infectious disease outbreaks or a pandemic. We used this a lot in COVID as well. Often, Internet Partner Services is beneficial after methods such as phone calls, letters, and field visits have been exhausted or have failed. When the only identifying and locating information the original person diagnosed with the infectious disease has or is willing to share is a screen name, for example, like a Grindr profile name, or an email address, then IPS becomes the most useful tool for investigating, for the DI professional to investigate. So using these technologies, I think it's becoming more and more mainstream, especially around texting, where we can reach out to folks via text messages, but otherwise also utilizing mobile apps. I am like Messenger on Facebook, that kind of thing. There are 3 types of notification in IPS. First, we have notification from the disease intervention professional. So the DI professional takes responsibility for notifying partners via email, apps, or social media, ensuring that notification is attempted and documented. The advantage of provider notification is that the agency is required to utilize more resources than traditional notification because the systems, policies, and protocols need to be in place before their use. So we want to make sure that you're not just like willy-nilly doing this using your personal information, your personal profiles. Your health department needs to have a policy about IPS in order for it to be an acceptable form of notification. Then we have notification from the original index case, and this is called personal IPS. The person notifies their own partners or contacts. This method has several disadvantages, including the potential for malicious notification of partners and confidentiality risks, since the partner will know the identifying information of the person notifying them. So again, folks kind of expose themselves to potential confidentiality risks if they notify their own contacts. This is true whether it's IPS or not IPS. And then lastly, once notified, partners may not have the necessary support or information to access appropriate testing and treatment. So just knowing you were exposed to something doesn't necessarily help the provider know what to do with you when you get there. Again, do you need preventative treatment? Do you only need screening? What do you need? And then we have notification via third-party sites utilized by the original index case. And this might be a site like tellyourpartner.org or InSpot, where they can send anonymized messages to their contacts notifying them of an exposure. IPS presents unique risks, including malicious notifications, like this is meaning intentionally sending false exposure notices, and privacy concerns. To mitigate these risks, the CDC recommends using secure jurisdiction-approved tools, verifying partner information before sending notifications, ensuring notifications are non-specific, protecting the index patient's identity, documenting IPS use according to local protocols, and providing follow-up pathways for notified individuals to access testing and treatment. So it may be something as simple as sending a message saying, I have urgent health information to discuss with you, please call me. And that way you can verify their date of birth and know that you're talking to the right person. Best practices for verification include having a good physical description to compare to available photos and asking the original person diagnosed with an infectious disease to share a contact's online profile picture and provide their screen name. Honestly, usually I just say, let's pull it up. Let's pull up your account. Let's go through it. Let's go through your messages, kind of see who you were having sex with over the last 3 months or whatever. And then I can see the profile pictures. I can see the handles, their kind of screen name and whatnot. That's probably the easiest way to do it if they're willing to do that. After people diagnosed with an infectious disease are contacted through social media, they often contact the agency where they were examined, diagnosed, treated to verify the legitimacy of a public health staff person contacting them through non-traditional means. So this is the biggest pitfall is folks don't buy it. They think it's fake because they wouldn't even imagine that the health department would reach them on social media sites. They'll be looking for confirmation to verify that the attempt to contact them was valid and urgent. Sometimes I snap a picture of my business card or my ID and send that to help folks feel comfortable with the process. Informing partners and clinical agencies about IPS practices at the health department can expedite the time it takes for a person diagnosed with an infectious disease or their partner to respond to an instant message or email notification. DI professionals should use their program's approved language for digital notifications and include the following information: name of the DI professional trying to reach them, program or agency affiliation, again, not being so specific that it's like, oh, my name's Melissa and I'm with the HIV program. We wouldn't really say that. We might say that we're with the section of epidemiology, for example. Contact information, your contact information, so they know how to reach you. And then just a brief message encouraging the person to contact you as soon as possible. Once you locate the person identified as a partner or contact, whether it's through IPS or traditional means, you need to notify them of their potential exposure and refer them for appropriate testing and treatment services. Each time a DI professional provides notification services, they should work to ensure that the person identified as a partner or contact knows the disease to which they were exposed. So first they need to know what it is, knows that the information is valid and the risk is real. Like they wouldn't pay me to call you if it wasn't a big deal. It's a big deal, I promise. Know that the information is confidential and then has the information they need to act quickly. Before informing a person about their exposure, the DI professional should verify their identity by asking them to confirm their date of birth. Confirming the correct spelling of their first and last name is another way to verify identity. When notifying a person named as a partner or contact, the DI professional should provide clear and concise information about the infection, including the name of the infection, potential consequences, and the available prevention, testing, or treatment options. It's vital that the DI professional answer any questions and address concerns without releasing any information that could reveal the identity of the index case or the original patient diagnosed with the infectious disease. Assessing the person's knowledge about the disease can be useful in motivating them to seek appropriate care. It's a delicate balance between using scare tactics and providing enough factual information about the potential health consequences of the disease to motivate the person to seek the care that they need. The DI professional can also ask the person if they have ever been diagnosed with the infection or had previous testing to help determine the appropriate next steps. So we want folks to understand like why it's important, why the health department has this process to reach out to them and let them know about the disease. We don't want to freak them out, but we want them to know the information they need to know to make an informed choice. Once the person has been notified, DI professionals should establish an action plan to ensure that they receive timely services for testing, treatment, or vaccination as appropriate. The action plan should be time-specific and include active referrals for services that consider any potential barriers identified during the referral process, such as transportation, location, hours, or access. DI professionals should establish relationships with staff at trusted clinics or community organizations to serve as referral sites. I don't know about you, but I always have my go-to people, and I will call with the person. I'll call my contact. I'll let them know, like, hey, I'm going out to do a field visit. I've been looking for this person forever. I think I'm finally going to find them. I'm going to be calling you to get them connected with an appointment. And then you can call a real person, not just like a phone tree. You can also follow up with people exposed to an infectious disease if they fail to complete the recommended medical services. So again, circling back and saying, hey, we had it all figured out. You were going to go to the clinic on Wednesday. It looks like you weren't able to go. Let's talk about what happened and making sure that you keep with it. Because if you give up, they'll definitely give up. That's my thinking. In some instances, a person with an infection may struggle to identify specific contacts or partners during an interview, especially if the exposure occurred at a large event or was anonymous. So venue-based contact tracing is a valuable tool for identifying additional people who may have been exposed to an infectious disease. Again, we did this a lot with COVID. We do it with measles. There's other diseases where this makes a lot of sense. TB, our respiratory things tend to work really well for venue-based contact tracing. Common venues where infectious diseases may spread include shelters, K through 12 schools and institutions of higher education, travel and transport, so airplanes, airports, buses, trains, social venues like concerts, conferences, bars, gyms, restaurants, congregate settings like correctional or long-term care facilities, and child care facilities. The benefits of venue-based contact tracing include easier recall and listing daily activities over the past few weeks. For example, just using a calendar and saying, like, based on your symptoms, it's most likely you were exposed a couple of weeks ago. What were you doing on the weekend of whatever it is, May 15th? It can be more palatable to some people to name a place or a setting rather than a specific person. It can be advantageous when people who were exposed are anonymous or unknown to the person diagnosed with the disease. So for example, like anonymous sexual contacts at a bathhouse or contacts with measles on a recent flight. There's potential to identify the source of infection and transmission among social groups at events and gatherings. This offers the opportunity to identify others who attended the same event or gathering to notify them of their potential exposure and assess their needs for services. You also have the potential to identify opportunities to expand access to services in the community. DI professionals and public health programs could partner with community-based organizations to facilitate community engagement and provide tailored on-site information, communications, and testing and vaccination events and services to groups of at-risk people and people associated with an identified venue. So like a workplace, a school, a supporting housing program, emergency or transitional housing, etc. My best example of this, when kind of in the thick of the COVID pandemic, I briefly was an interim manager of the case investigation program for the Philadelphia Department of Health. And they were having a really hard time eliciting contacts from a kind of closed Orthodox Jewish community. And they kept trying. They were doing case by case, and they would, you know, interview every case. And every time they got shut down, they couldn't get any contacts identified. And they brought it to me when I had first started with their program. It's like, oh, we don't know what to do with this. We're not getting anywhere. And they just keep testing positive. And I was like, well, why don't we talk to the rabbi and really find out what the barriers are? And honestly, in a group like that, you can kind of assume they're all having contact with each other. So rather than kind of hammering this one by one case investigation process, we worked with the rabbi to offer kind of culturally appropriate, culturally sensitive testing services for that Orthodox Jewish congregation. And we really reached the same goal. We tested over 500 people. And we never would have gotten 500 names from this group of people. It just didn't work for them. So, this venue based contact tracing was a really good approach when traditional contact tracing didn't really make sense. That was a big juicy section. So, we have lots of keywords for this section, and they can all be found in your study guide. Let's see how we're doing on time. Okay, we've got so much to do. Um, okay, so, oh yeah, somebody asked, is tell your partner back. I actually don't know if it's dead or not dead. So if it's dead,
Yeah, it doesn't look like it's
don't
working.
use it.
There's
Okay.
a tellyourpartner.com, and then I found some other sites, but I can't, I don't know if these are legitimate. They say they are, but it's hard to know when if you're not familiar or if they don't come from a government source.
Yeah. Okay. Okay. So I'm going to take a drink of my iced tea. I feel like an auctioneer or something, like I've just been talking now for an hour and 20 minutes. So I do apologize this isn't more interactive and that we have so much to talk about. But hopefully it's resonating with you and helping you feel prepared for the exam. Okay, so now we're going to talk about motivating participation in disease intervention services and interviews. So, a person-centered approach prioritizes the individual, considering their values, preferences, and experiences at the center of the discussion. This creates a safe, supportive space where they are heard, respected, and empowered to make their own decisions. So again, not just reading from a form, not being like my colleague Paul, who used to literally say the same thing to every person, but really tailoring so it feels like a conversation and they feel important. The person-centered approach builds trust, which is especially important for those who may be hesitant to share sensitive information about their infection, personal experiences, and others who may have been exposed. Valuing the person's autonomy and personal experiences helps them feel more comfortable, understand the need for intervention, and actively participate in discussions or interviews with the DI professional. To accomplish this, the DI professional should attempt to make the interaction conversational, avoiding the use of scripts or forms and allowing the interviewee to guide the conversation. So again, go where they're taking you. Don't be so stuck on your little list of questions that you don't take an opportunity to let them drive the bus. Because then if it feels like a conversation, they'll be much more likely to participate and hang in there with you. Um, while DI professionals are tasked with gathering a series of data elements, this process should not take priority over placing the person receiving services at the center of the interaction and using a person-centered approach. A skilled interviewer can elicit the required information while maintaining a conversational tone and tailoring the interaction to the unique circumstances of each person that they interview. So this person-centered approach, we had years ago now, our first case in a real long time of infectious syphilis in a heterosexual female. This was up in Alaska, and it had mostly been among men who had sex with men for decades. And she was incarcerated with a raging secondary syphilis rash, and she was tough. And so they were like, Melissa, we need you to go talk to this lady. And she told me, I was like, how do we, what do you think's going on? Tell me the story. Where are you camping? What's happening? Who knows who? And I got her kind of to open up about the situation. And she said, if you can find this one guy and get him to help you, everyone will talk to you. So we did. We went out there, we found the one guy, and he was really that gatekeeper that made people feel safe to interact with us. And we ended up partnering with our mobile syringe exchange van. We did rapid HIV and syphilis testing. We brought coffee and snacks and new clean needles and syringes and Narcan. And we went out to the woods and spent a whole afternoon out there testing people. And the guy came to me on the side. He kind of waved me over after all these people he knows were getting tested and eating free sandwiches. And it was, of course, snowing sideways, but that's neither here nor there. And he looked at me and he said, "Nobody's ever cared about us like this before." And that was when you know, like, this is why we do this person-centered approach, because it's not one size fits all. And we really sometimes have to do the work to build back the trust that people have lost in the systems that have abandoned them. So that's where the juice is. Just remember to put people in the center. Now we'll talk a little bit about motivational interviewing. This is a technique that I'm going to teach you in 30 seconds, but I took a 3-day course on motivational interviewing, so I don't pretend like you're going to know how to do it, but you will understand the phases of the process. So the stages of change model was developed by Prochaska and DiClemente, really for the substance use space, but it helps to tailor interventions based on a person's readiness to change. The 5 stages of change in this model are the pre-contemplation, contemplation, preparation, action, and maintenance. In that pre-contemplation or contemplation stage, a gentle approach using reflective listening and empathy helps individuals recognize the importance of intervention. So they haven't even really thought about change yet. During these stages, the DI professional can ask questions like, how would your life be different if this changed for you? Or how important is it to do whatever it is, to help the person reflect on their readiness for change. As they progress through the model, intervention strategies can become more action-oriented to support their commitment to change. So once they sort of teeter over the edge into preparation, then they might be ready for more action steps. And this is where the DI professional can help guide the person through developing an action plan using prompts tailored to their situation. So again, we're not educating them, right? We're like, well, you know what you should do? You should use condoms every time. You should get on PrEP. You should take DoxyPep after you go out to the bathhouses. And this is what you should do. That's really not motivational interviewing. Instead, you can ask prompting questions like, what is one small thing that you could do to start making this change? Don't assume they've done nothing. People are probably doing all kinds of things to try to reduce their risk already. So we're really just working with them to think through their own willingness, their own steps that make sense in their world. During the maintenance stage, the person may need support to maintain the new behavior, which could include joining support groups, connecting with individuals in a similar situation, or having occasional conversations with the healthcare provider or the DI professional to discuss their progress and offer encouragement. I had a gal that was in a serodiscordant HIV relationship. She was married, her husband had HIV. And I saw her every 6 months, and she just wanted to talk and get tested and talk through considerations around should they have children or not, or whatever. And because she didn't have any diseases, she didn't have a lot of resources available. So I became that resource for her. And I think it kept her engaged in the process and really thinking about her own risk. Motivational interviewing is a collaborative, goal-oriented approach that helps individuals explore and strengthen their motivation for change. By exploring and addressing uncertainty and internal conflict, motivational interviewing supports meaningful choices and decision-making. So this is just a technique that you can use, but there's lots of other techniques for interviewing. Let's talk about some of our effective communication strategies, or what we call OARs. So OARs stands for these sort of 4 key techniques. Open-ended questions, that's the O. A is affirmations. R is reflective listening. And S is summarization. So DI professionals play a key role in creating a supportive environment. The way questions are framed, such as asking why someone took a particular action, can unintentionally lead to defensiveness and resistance. Well, why aren't you using condoms with your partners? Ugh, that's so judgy. Using effective communication skills helps people being interviewed think about the benefits of intervention, leading to a more active participation in disease intervention. So open-ended questions encourage thoughtful responses, create space, right? We need to have them tell us their story. Affirmations really validate the strengths and progress that they've made. Reflective listening shows an understanding and builds trust. And summarization reinforces key points and clarifies insights. So ORS, remember that, write it down. So let's talk about open-ended questions, the first one. This is my favorite. And it takes a long time to get good at this. Even if you think you're doing it, you might not be doing it. So let's talk about it. Open-ended questions foster an atmosphere of respect, acceptance, and trust by encouraging individuals to express themselves more fully. Using questions that begin with who, what, where, when, and how during an interview can build rapport and result in the elicitation of more detailed information. Open-ended questions enable individuals to share their stories by elaborating and providing more detailed responses. While questions that begin with why are technically open-ended, they should be used with caution. When a DI professional conducting an interview asks an individual why they did something, it can unintentionally come across as judgmental, leading to defensiveness and resistance. So yeah, why is sometimes fine, but sometimes it also feels really judgy. So just kind of use it sparingly. Instead of why, I might say something like, what gets in the way of using protection? Or something like that, rather than just a straight up why, because that immediately makes people feel like they have to justify themselves. Use of closed-ended questions can lead to limited responses such as yes or no, which can reduce engagement. Closed-ended questions usually begin with can you, do you, are you, or have you? Can you tell me what he looked like? Do you have a good physical description for him? Those feel like open-ended questions because you're asking what you're supposed to ask, but they're closed-ended. So now we're going to practice a little bit with open-ended questions. So we have these kind of 3 examples, and you can just use the chat for this. We don't even have a poll, even if we figured out how to do the polls. We don't have a poll for this, so we'll just use the chat. So the first one is on recent travel. So what is an open-ended question that you could use to elicit recent travel? The closed-ended version might be, have you traveled anywhere in the last 30 days? How would we reframe that to be open-ended? And you can just go ahead and put stuff in the. Gary said, once the client starts talking, don't interrupt them. Yes. You can guide them. Sometimes you have to interrupt them and be like, sounds like you have a lot going on. Let's talk again about, about your infection. Where have you traveled in the last? Yep. Oh, I see Roman or Roman Garcia. Can you tell me? No, see, that's close-ended. That's a trap. Can you tell me where you have gone to visit in the last 30 days outside of the city? You could just keep that same question, but start it with where. Where have you visited in the last 30 days rather than can you tell me? 'Cause technically, they could say, no, that's a closed-ended question. It's a pitfall. Tell me about your last travel. Where have you traveled lately? What fun places have you been lately? Yeah. Have you recently taken a vacation? I'll say again, that's a closed-ended question. You could ask, when's the last time you went on vacation? Um, yeah, so folks are getting the idea. We have more when and where questions showing up. So yeah, we just want to focus on those kind of open-ended opportunities for them to tell us a story. When's the last time you traveled outside of your community? Who else traveled with you? How often do you leave the area for work? Those are the open-ended ways. Now let's do one on condom use. What's an open-ended question to learn about condom use behaviors? The closed-ended version might be, do you use condoms when you have sex? We've probably all asked that 1,000 times. So what's a good open-ended way to elicit condom use? How often do you use condoms? When's the last time you used a condom? How often do you use a condom with your partner? Yep. Lots of how often's. What's your experience using condoms? I like that. That sounds like it would give you a story. Yep. Okay. Some of the ones I had were how often do you use condoms for sex? Which partners are you most likely to use condoms with? This one's a sneaky one because it's a double, it's a twofer, because you're asking about condom use, but you're also likely to get partner information. So, which of your partners are you most likely to use condoms with? And you might accidentally get another partner named. Um, how do you feel about using condoms? Again, don't be afraid of feeling questions. Thinking and feeling questions, I call them. Things that get folks, you can tap into their feelings. Yeah, what condoms do you enjoy using? Yeah. Tell me what you know about condom use. Okay, cool. Now, our last one we have is for eliciting symptoms. This comes up no matter what the disease is. We're always asking about symptoms, right? So the
Listen,
closed-ended question, have you had any symptoms?
we do have a poll for this if we want to try, just try to launch.
Oh, sure.
Okay, symptoms. Launch. Do you see anything?
I don't, but I don't think I will as a presenter. No,
Mm,
people are
okay. Yeah,
not.
it's not, it doesn't not appear to be working.
Okay.
All right.
Well, you know, you can put this all in the evaluation. These girls did not know how to do polls, which is so true. Tell me about your symptoms. Yeah. So it's interesting. When we ask about symptoms, sometimes people don't know what the symptoms are necessarily. So when we tie it to like, tell me about your symptoms, sometimes what I will do is ask something like, what unusual changes have you noticed in your health? When is the last time you noticed something on your body that isn't typical for you? So that takes it away from like a specific symptom to just them kind of thinking and reflecting about their health more generally. Now, if it's a specific disease and you're focusing on like cough or fever or a symptom they already have, then you can really be focused and say, when did the rash begin? When did your cough start? That kind of thing. What brought you in for testing? What prompted you to go in? Yeah. So these are good. What symptoms are you experiencing? Yeah. So sometimes again, you can kind of reframe symptoms as changes or, when's the last time you noticed something unusual for yourself and your body or your health, that kind of thing. So just focusing on those open-ended opportunities for engagement. Let them tell you their stories. Another technique, and I saw this in the chat already, so we're not going to practice it because folks were doing this naturally anyway. You guys obviously already know how to do a lot of this stuff, are polite imperatives. So they're kind of along the same line as open-ended questions, but these are more like statements that encourage the person to provide information. So we can say, tell me a little bit about your alcohol use, or help me understand more about your relationship with your baby's father. Let's talk a little bit about your diagnosis. So these are technically not questions. They're called polite imperatives, but they are these kind of leading statements that encourage people to share information. Then we have our affirmations. Affirmations are positive, encouraging, and supportive statements that communicate understanding, appreciation, and validation. They help strengthen emotional bonds and build confidence. So, whatever it might be, like you did such an amazing job using your personal protective equipment. Like, say there's a big outbreak in a nursing home and you're working with a healthcare provider who got exposed and is diagnosed with something, and they're feeling bad about it, right? They're like, oh, I did everything I could. I thought I was doing, like giving them that compliment, that little bit of encouragement, like, that was really hard. And I know that you did the best you could. Um, Gratitude. Don't underestimate the benefit of gratitude. This can be such a really good mover of the interview. It's just acknowledging, like, I really appreciate you sharing this information with me. Um, it's really great to see how you care about your community or how you care about your contacts. And then like I'm here for you. Like I know this is hard and I'm really here to support you through this process. So those are some of our affirmations. And we have reflective listening. Reflective listening involves actively paying attention to both the words and emotions a person expresses. It ensures clear understanding by accurately interpreting the message and responding in a way that affirms comprehension. DI professionals often repeat key points, allowing individuals to hear back their own thoughts reflected back for them, which strengthens communication and prevents misunderstanding. So there's kind of three types of active listening. We have repeating or rephrasing, which is basically restating what the person said in a slightly different way. Then we have paraphrasing, summarizing the message to clarify understanding. And then we have reflection of a feeling, which is highlighting emotional aspects to show empathy. Together, these communication strategies create meaningful connections, encourage engagement, and build trust. And I will say, for those of you doing largely telephonic interviews and notifications, reflective listening is a really important tool. They can't see you. They can't see your kind eyes. They can't see your attentive gaze. So using these reflective listening techniques can really help bridge the gap when you don't have that nonverbal communication for that connection. So just remember, they can't see you. You're behind a black box. And so you might need to do a little bit more of this reflective listening, affirmations, encouragement over the phone, since they're not able to interpret your body language. Then we have summarization. Summarizing helps keep conversations clear and is useful at the transition point, such as when someone shares personal experience or finishes discussing a topic, or when the conversation's kind of wrapping up. It ensures both participants are aligned, helping to guide the discussion towards the next steps or meaningful change. Summarization is used effectively and starts with clear statements like, "Let me see if I understand so far. Here's what I've heard. Let me know if I missed anything." This approach maintains open communication and fosters understanding between both parties. And it's actually a really great opportunity to check in and see if you're headed in the wrong direction. Maybe they'll be like, "No, that's not what I said," or "That's not what I meant." So this summarization can also help keep the train on the tracks. If maybe it is somebody that just keeps talking and talking and talking, and you're kind of losing track of the story, and you're like, "Whoa, let's bring it in a little bit." This summarization can help you with that. Now we have our effective communication skills. And I will admit, I don't think we're going to have time for practice questions. We might, but this is just such a chunky domain that I'm not real sure. So we're going to see how we do. So problem solving is an effective strategy that enables DI professional and the person receiving services to collaborate in identifying challenges, exploring solutions, and developing a plan of action. This approach helps individuals navigate barriers like fear of stigma or confusion about treatment, making it easier for them to engage in care. Encouraging ownership of their health decisions empowers them to make meaningful steps towards better outcomes. Addressing problems as soon as they come up during the interview can help keep the interview on track. For example, if the interviewee seems distracted and keeps glancing at the time, the DI professional could pause the interview and check in by asking something like, "I noticed you keep looking at the time. Is there something you are concerned about that we need to address?" It may be something as simple as needing to make a quick phone call or check on their child or putting more change in the parking meter. But by addressing the person's concerns, the DI professional maintains rapport and creates a supportive environment for the interview to continue. If you don't do this, you're probably going to lose them. Honestly, they'll just be like done because whatever they have brewing under the surface is going to prevent them from being fully engaged. Then we have active listening, which is kind of like the little sister of reflective listening, right? The DI professional can use active listening to convey that they're fully engaged in the interview process. And again, this is super important for telephonic work too. Not only, but more so. It's important to maintain eye contact if you have the benefit of face-to-face. And if it's culturally appropriate, there are some cultures where direct eye contact is actually not appropriate. Avoid distractions. Don't look at your phone. Oh my gosh. Don't look at your phone. If it buzzes, don't even have it buzzing. Don't have it on. Just really focusing on the person being interviewed and occasionally providing verbal affirmations during the conversation makes them feel heard and understood. So active listening can also involve nonverbal techniques like nodding your head, smiling, leaning forward, maintaining eye contact. Again, that's if you're in person. If you're not in person, then some of these little interjections like, "Oh, that's interesting," or, say they're telling you some crazy story. You could be like, that's so crazy. I can't believe that happened to you. That's okay. That tells them that you're there with them, you're paying attention. Or just like, go on, or, oh, I see. Huh. Interesting. Like, whatever it might be. Then we have assertiveness. So, assertiveness is kind of that ability to express your thoughts and feelings clearly, confidently, and respectfully without being overly passive or overly aggressive. So, it's that balance between, like, would you mind if I ask you a few questions about your partner? That's pretty passive versus, you know, you tested positive for an infectious disease and I need to get a list of everyone that you exposed. That's pretty aggressive. So it kind of involves having that good boundary, standing up for yourself, considering the perspective of others. But it helps you to set boundaries as well, and really advocate for your personal and professional needs, not getting too roped in with everything. There's sometimes our folks have a lot of drama. Um, but it really involves clear and direct communication. I want to make sure you have the right information about your treatment options. Respectful and non-judgmental. I understand this may be difficult, but these steps can help protect your health. So not giving in to that sort of like, like, well, I don't want you in my business. And you sort of push back. It's that not giving up when they first balk or, where it seems like they're shutting you down to really keep at it and use that assertive communication. Again, avoiding aggression, you need to do this now, or this is why this is important for your health. That kind of lecturing can come off as aggressive too. That sort of over-educating, lecturing, talking at people. And then that passivity, if people start to refuse the interview, it's really easy to be like, okay, well, thank you for your time, and just sort of hang up the phone. Where really that assertive communication would keep you in the ring and keep you working with them to fight through that resistance. Then we have empathy. Empathy demonstrates an understanding and care for a person's feelings and situation, which fosters trust and cooperation, particularly during sensitive health discussions. Some folks may not need a lot of this, like, maybe in foodborne, people are like really happy to talk about their diarrhea and they don't mind, provided it doesn't feel altogether that personal. Where when we're looking at more, sexually transmitted infections, close contact, that kind of thing, it might feel more personal. But recognizing and respecting that person-centered background is crucial, sort of using that respectful language, maintaining eye contact if it's culturally appropriate, and employing appropriate body language. Um, Beliefs shape attitudes toward illness, testing and treatment, and healthcare and medical management. It's important to make time during the interview to demonstrate empathy. This conveys that the DI professional is concerned about the person and recognizes that the situation may be stressful for them. Saying something simple like, I understand how hard it is to share so much private information, and I really appreciate you talking with me. Or I can only imagine what it must be like to hear that you've been diagnosed with this infection, that kind of thing. Then we have our respectful and adaptive communication. So this is an opportunity to develop an awareness of people's different backgrounds and communication styles. We're all chameleons, right? We bring ourselves into the session, but we also learn how to adapt our methods, our way of communicating to the person sitting in front of us. And this kind of takes ongoing self-reflection and humility and active learning to identify those gaps. When I was really pretty new in my career, I was working closely with a colleague from the social hygiene division of the Navajo Nation. And he he was very philosophical and he said, even a rabbit must sometimes be still. And I think he was telling me that I talk too much. But it gave me a moment to realize that I was too big. I was too big in that moment and perhaps even too big with that population. And it really made me rethink for the rest of my career the way that I interact with people in different settings. You can also practice attentiveness, both verbal and nonverbal cues, to recognize when certain approaches may not align with a person-centered preference. Sometimes those direct questions are just really off-putting. I remember interviewing a very young Alaska Native woman, and she had a hoodie up over her face. All of her body language was closed, and she was not going to talk to me. And so I gave her my notebook And I asked her to write down the names of her contacts, and I left the room. And she did. And she wrote them all down, but she was not about to have a conversation with me about it. So sometimes we just have to be flexible and adapt our communication style. And using these person-centered approaches really does help, and motivational interviewing techniques, all of our communication skills, um, helps people feel respected and motivated to engage in our intervention services. People need to feel safe and respected to be willing to share very personal details about themselves. If we haven't done the work to build that rapport and create the safe space, we're probably not going to get very far. So that was section 4. And here are our key terms. I am super conscious of time. I have 9 minutes. I don't know. We'll see how we do. Might go a little long, which I thought it might with so much to cover. This is the longest domain though. So for all of us, once we get through all of this, the rest are much more succinct than the interviewing chapter. So now we're going to talk about some history taking, using the 5 Ps. And again, this was coined for STI and HIV intervention. So the Ps really align best with those infections, but the concepts can be adapted to any disease etiology. So the 5 Ps, we have partners and contacts. Then we have practices or risk behaviors, protection or prevention strategies, past history or previous infection, and then pregnancy intentions. Pregnancy can be relevant in lots of different diseases. In order to take a really good risk assessment, we rely on a range of interpersonal and analytical tools during the interviews, motivational interviewing, active listening, problem solving, all those things, but also question framing. Question framing really is sort of skillfully framing these questions to ensure that essential details are gathered comprehensively. This is again one of those kind of art of interviewing techniques. Skillfully frame questions and pulling in information discovered during the interview and investigation ensures that essential details are gathered comprehensively. So these are those like really juicy, well-placed questions. And then integrating medical chart reviews and consultations with healthcare providers adds depth to the assessment process. So it helps to fill in the blanks. The person is obviously a great source of information, but may not be the only source. So it's good to kind of corroborate your information through these other sources. Documentation is a vital part of public health. Maintaining detailed documentation facilitates continuity of case management and is useful for reference in future investigations. The better you document, then the next person that has that same person come up will be able to build on what you've documented for them and shared about your investigation. The documentation kind of key elements are the dates when the action was taken, the action that was taken, and any referrals or services provided, and the follow-up. These thorough records allow you to monitor the health condition, assess testing and treatment, track disease progression, evaluate effectiveness of intervention, identify patterns to inform future strategies, comply with legal regulations, and supports quality assurance. Effective documentation, integrating medical, social, and behavioral data helps create effective plans. For example, when investigating an outbreak, DI professionals document symptoms, exposure history, and social factors like environmental or living conditions to understand how a disease spreads. DI professionals use documentation to address barriers, foster collaboration, and promote fair access to services. Follow-ups after infection or exposure play a key role in public health efforts. Following up helps monitor health, ensures treatment adherence, prevents disease spread, identifies long-term effects, and helps to educate and empower communities. So we're not just like a one and done, right? We go, we do our interview, and then we know they never hear from us again. We might call a week later and ask about a Herxheimer reaction or ask if they were able to get an appointment, find out if their symptoms are improving or getting worse, and make a referral. So it's really important that we follow up. Okay, blazing through section 5. Now we have addressing needs and barriers. So, an understanding of person-centered backgrounds and the social and economic conditions that affect daily life is essential for ensuring fair and consistent access to services. DI professionals must respect a wide variety of person-centered backgrounds and consider key social and economic factors that contribute to health. People at risk for infectious diseases often face obstacles like stigma, limited healthcare access, confidentiality concerns, fear of judgment, mistrust, and financial difficulties. These barriers can be practical, like transportation, or systemic, like distrust of healthcare systems. To ensure interventions are accessible and effective, DI professionals can use culturally sensitive or person-centered communication to engage communities, build trust and rapport by addressing concerns, and show the real benefits of interventions to encourage participation. This is sort of what we did with our folks that were living in an encampment where we were concerned there was a syphilis outbreak going on. You know, we took everything to them. We built trust. We built relationships. We brought food. We had coffee donated by Starbucks. That was a funny conversation. Like, hey, Starbucks, will you give us free coffee? Because we think people have syphilis in the woods. But you do what you can to build those relationships. And it goes a long way, really, to having a sustained, because you're going to see these folks again, right? Inevitably. So that first impression really matters. Okay. So now we have an opportunity to talk about what are some appropriate questions to ask to assess barriers to accessing services. I'm just going to kind of show my examples rather than doing it in the chat, just for the sake of time. This one was really controversial. This is funny. I've used this a lot, but some folks, when we went through the review process for the slides, were like, that sounds really judgmental. But, you know, asking someone what might make it difficult for you to go to the clinic for testing and treatment. Maybe you don't say it that exact same way, but like what might get in the way? Or what's going on for you that could get in the way of making this a priority? Like you're really just giving them an opportunity to be honest with you. If, you know, like maybe they have to go do a UA and meet with their probation officer and they literally cannot go to the clinic or they will be arrested. If you don't know that, you think they're just being non-compliant. So helping them think through the barriers so that you can help them work with them to problem solve. But if you don't know what the barrier is, you don't know what you're problem solving. Common barriers include lack of healthcare access. So folks that don't have insurance and have chronically not had insurance really don't trust free services, sliding fee scales, that kind of thing. They're just afraid they're going to get a bill. Concerns about confidentiality. This can be exacerbated in rural and remote communities, certain political, geographic areas, that kind of thing. Not believing that their diagnosis or exposure is valid. If they don't believe it's real, they're going to have a real hard time getting them to go in. Concerns about stigma or judgment. Lack of stable housing or transportation. If you don't know where you're sleeping, it might not be a huge priority to go to the clinic, especially if you don't have symptoms of something and you're not even sure if it's legit. And then active substance misuse or mental health conditions. You know, this can be a significant barrier. I had a person I was working with who was he was unhoused, he had untreated HIV, and we were trying to get him back into care, get him to go in to get labs and everything, but he had to do all this paperwork to sign up for the Ryan White program at our local FQHC. It was hours long, hours long. And there were so many times he almost left. And I asked him, I was like, hey, you know, like, I get it. This is really tough. What do you need to stay until we're done? And he said he needed to go outside and take a drink. And I was like, huh, well, okay. I was like, do you have it with you? And he was like, yeah, I just gotta have a drink. And he did. He went outside. And I guess, I don't know, I wasn't with him. He took a drink and he came back in and we finished the appointment. Maybe that's not appropriate. I don't know, but it got him through this process of re-engaging in care without judgment, without fear of me being all systemsy about it. It's what he physically needed to hang in on that appointment. Addressing challenges, you know, has really good benefits. By addressing challenges, we can ensure that people infected with or exposed to infectious diseases can access the medical and supportive services they need to prevent negative health outcomes. Public health efforts can reduce the spread of disease and exposure, ensure fair and effective health outcomes, and improve overall community health. Strong community partnerships improve public health interventions by ensuring comprehensive care and support. Connecting with local providers, support services, and organizations helps address a wide range of needs, like working with your local shelters, correctional facilities, mental health services, and rehabilitation facilities. Those relationships that you can tap into to help advance your folks really are valuable. And this helps ensure that vulnerable populations receive tailored assistance. Special populations require particular attention when addressing needs and barriers. For example, people who use drugs may need harm reduction, needle exchange services, access to Narcan, and substance abuse or mental health treatment. People experiencing housing instability often struggle with continuity of care and require assistance with accessing housing resources and transportation. People who are victims of intimate partner violence may face unique safety concerns that affect their ability to engage in care and their access to referrals and services. Pregnant women require specialized interventions to protect both maternal and infant health. People experiencing mental health crisis may need integrated care that addresses both mental and physical health. Refugees, immigrants, and migrants face challenges with healthcare access, language barriers, distrust of systems, and person-centered contextual barriers that may prevent them from accessing the necessary services. By addressing the specific needs of these groups, DI professionals can design more effective and compassionate interventions that meet the needs of these groups. Interpreting and explaining lab results clearly is a vital part of case investigation. These results help confirm diagnoses, rule out conditions, and identify disease-causing agents. A DI professional may need to explain results to a person with an infection, a person exposed to an infection, or a healthcare provider. The DI professional should tailor their approach and ensure they are communicating at the person's level of understanding and health literacy. For example, the DI professional may need to simplify the explanation for a person who tests positive for infection, but can use more technical language when talking to a healthcare provider. To ensure understanding, use plain language, interpret the results, clarify what the results mean and what they don't mean, assess comprehension, ask follow-up questions, and ensure the person understands the material. Avoid giving medical advice. Always refer individuals to their healthcare provider. Effective communication helps guide treatment decisions, public health responses, and delivery of medical care. Laboratory testing algorithms streamline the diagnostic process, ensuring accurate and timely identification of pathogens. Pictured here is an example of the reverse syphilis algorithm. DI professionals should be familiar with the testing algorithms for their diseases of interest and assist with the interpretation when necessary. Here's our keywords. Now we're in the home stretch. A little bit on confidentiality. I'm confident you all know about HIPAA and whatnot. We are a little bit over, but I'm going to go ahead and finish. Again, this is being recorded. If you need to drop off, hopefully most of you can hang in for another few minutes. Confidentiality is a legal requirement governed by laws like the Health Insurance Portability Accountability Act and state or local regulations that govern the confidentiality of public health records. Confidentiality is a cornerstone of effective communication and ethical practice in public health, particularly when discussing personal information tied to sensitive topics like infectious disease. Protecting PHI. Information about an infection or health condition is shared only with people who are either authorized by the person or legally permitted to receive it, typically with the person's informed consent. Any disclosed information must be carefully protected in terms of both storage and use. To ensure this, programs must establish clear policies and procedures for data protection and provide training to health professionals on how to manage sensitive information appropriately. This not only creates a foundation for effective communication, but also supports tailored person-centered care, ultimately upholding the investigation objectives, public health goals, and individual well-being. To protect PHI from unauthorized access, DI professionals take several key precautions. These include maintaining personal and medical records in secure access-controlled office environments, bringing only the necessary level of identifying information during field activities, ensuring that interviews and notifications are conducted in a confidential environment where unauthorized parties cannot hear confidential information. This can be challenging in the field, but we'll talk about that in Domain 3. Disclosing or limiting the release of information required for medical management. In the context of gathering sensitive information and demonstrating respect for an individual's privacy, Building trust is vital in creating a secure environment where individuals feel safe sharing personal, private, and often sensitive details. Confidentiality is essential in health-related conversations, ensuring the privacy, trust, and dignity of individuals discussing sensitive information, such as their health status. This information should only be shared with authorized medical professionals. Confidentiality matters because it encourages honesty. When people trust that their information will remain private, they're more likely to share accurate details, which is critical for disease intervention. It reduces fear and stigma. Confidentiality prevents individuals from worrying about judgment or repercussions, making them more likely to engage in care. It improves tailored support. With complete and open information, DI professionals can provide better interventions. When communicating confidential information to a person diagnosed with or exposed to an infection, it is essential to ensure that the information being released is being released to the appropriate person. Before discussing specific disease information, the DI professional must verify the identity of the person by asking them to confirm their date of birth. At the start of an interview, clearly explain reasons for verifying identity, what will be kept private, such as personal health details, legal limits of confidentiality, for example, mandatory disease reporting, and who has access to the information, for example, their healthcare provider. For example, to verify the identity of a person, the DI professional can begin the interaction saying, I have important health information to discuss with you, but before we can proceed, I need to confirm your date of birth to make sure I'm talking to the correct person. This helps to protect your privacy. When conducting interviews, the physical environment must be secure to prevent unauthorized third parties from overhearing protected health information. Super challenging in some settings, like in a shelter, for example. Sometimes the DI professional can perform the interview in a controlled setting, such as a clinic room, an office with a door, or even the vehicle. When encountering a person diagnosed with or exposed to an infection in a field setting, it can be more challenging to find a secure environment. If a DI professional locates the person they need to interview in a field setting where other people are nearby, they must do everything possible to find a secure location. This can include techniques like asking the person to step outside to speak if there are other people in the building, using the DI professional's vehicle, walking the person to a private location nearby, or asking to use a private space, like a bedroom, an office, or a room in a clinic. And here are the keywords for section 7. Now, oh my gosh, we did it. So much information. Thank you so much. So we do have some practice questions, and if folks want to stay on the line, I'm happy to walk through the practice questions if folks don't need to hang up. So I guess let's stay. Okay, Merced said, let's stay. Let's do it. All right, we're going to walk through our practice questions on interviewing. We've got 10 questions. We'll just kind of go through them to give you a sense of what might be on the exam pertaining to domain 2. So question 1, what is the first thing a DI professional should do when they receive a new case? Freak out. Not really. Okay, record search all available resources, call the person and verify their identity, or conduct a field visit. And I think we'll just put it in the chat. For some reason, the polls are dead.
Yeah, the polls are not working. I tried again to bring it up.
Okay. No biggie. Folks are cool about using the chat. And it looks like everybody agrees that it's choice 1. Before making contact or conducting a field visit, DI professional should review all available information, lab reports, medical records, registries, to prepare for the case investigation and avoid duplicate or unnecessary contact. Again, maybe they were named as a contact a week ago, and that's why they went in and it got assigned to you, and they already know. So yeah, it's definitely good to check all your available resources. Question 2, which principle is practiced when notifying partners of exposure without revealing the identity of the person who named them? Compliance, confidentiality, or assurance? Okay. And it looks like folks are in agreement that it is choice 2, confidentiality. So again, these are questions that you might find on the actual CDI exam. Confidentiality is a cornerstone of partner services. Partners are notified of potential exposure without ever learning who named them, ensuring trust and protecting privacy. So these other words sound legit: compliance, assurance. And the real trick of the exam, kind of the key that you need to unlock, is just sorting through the noise, even though there are terms that seem legit, really going with what you know to be true, which is confidentiality. Okay, question 3. Who would be allowed to participate in a partner services interview without violating the confidentiality of the person being interviewed? A medical assistant who's drawing blood, a friend or parent who wants to join the interview, a supervisor for quality assurance, or someone for language interpretation. And I will say the caveat to this is this one kind of assumes STI, HIV. Like if it's lead or measles and the patient is 6 years old, this answer might be different. So when you see the term partner services, that's your clue that this is probably more of an STI HIV scenario. Minors are treated differently depending on the disease. So for this one, we have, yes, the answer is 3. Supervisors may join for training or quality purposes, and interpreters may be included to ensure clear communication. Others should not be included. Do everything you can not to use a family member for interpretation. Do the work. Get a real interpreter, because some of those questions they are not going to answer honestly if it's their like 13-year-old son that is interpreting for them. What techniques should a DI professional employ to obtain a detailed risk assessment when conducting an interview? Record searches and partner elicitation, health education and treatment advice, open-ended questions, and active listening. Give folks just a little time to think it through. Looks like we've got strong consensus for number 3. Yes. Techniques. So we're thinking about interviewing techniques, communication techniques, right? Not steps, but techniques. And so that's where we see that open-ended questions and active listening elicit detailed, nuanced information and build trust, making them essential for accurate risk assessment. Super excited to see that y'all are getting these questions. It just builds confidence, right? This is real stuff that might really be on the exam. So obviously you know what you're doing. What information should the DI professional try to obtain for each person identified as a sex partner or contact? This is going back to our smiley guy with freckles, right? Name, exposure dates, locating, and description. Number of partners, name, contact information, and social history. Name, location, description, and risk assessment. So sometimes our exam questions kind of have one little element that's not quite right, just to kind of, we call them distractors. Those are our wrong answers. So really look through, try to take your time on the exam and make sure that you're catching everything. And for this one is number 1. Totally like baseline thing you need to know: name, exposure dates, locating, and description for contacts or partners. Okay, what is it called when a DI professional determines what the person diagnosed with an infection knows about the disease? The interview, medical history, or disease comprehension? And this was sort of one of those steps in our interview format where we take time to make sure that the person understands the disease. And for that one, looks like folks are on the right track with choice 3, disease comprehension. Assessing disease comprehension helps the DI professional understand the person's baseline knowledge and tailor education accordingly. Again, folks don't walk in knowing nothing. It's really insulting if we just start talking at people and educating them, because a lot of times folks have some awareness. It may not even be correct, but they know stuff and they like to tell you what they know. So really checking in with them about what do you understand about this infection? What have you heard? Gives them an opportunity to talk to you. What is expedited partner therapy, EPT? Providing prescriptions for a person diagnosed with an infectious disease to take to their partners, permitting the DI professional to take prescriptions to the field to hand deliver to the sex partners, setting aside dedicated clinic appointment slots for only those identified as being sex partners. This one's kind of tricky because honestly, I've seen all three. They're not necessarily called EPT, but they are things that happen in real life. So for EPT, we've got choice 1, providing prescriptions for a person diagnosed with an infectious disease to take to their partners. EPT allows people diagnosed with an infection to deliver medication or prescriptions to their partners without the partners needing a clinic visit first, reducing delays in treatment. Now, I did see some choice 2s. That would really be something we call field delivered therapy. It happens all the time. I did it in Alaska all the time, and we'll talk about that in domain 3. We have field delivered therapy, which is a little distinct from EPT. Question 8. When interviewing a person diagnosed with an infection, what is the best way to elicit information on people who were exposed? So we get to choose like your question. Have you slept with anybody recently? Tell me about the last person you had sex or shared drugs with. You've been diagnosed with an STI. You must disclose your partners to me. Like folks are pretty well in agreement on this one. So for this one, choice 2 is our best option, right? This is one of those leading questions, kind of our little statements that encourage people to open up and tell a story. Tell me about the last person you had sex or shared drugs with. This open conversational prompt is less intimidating, avoids judgment, and encourages recall, making it more effective than blunt or direct approaches. Question 9. What is the primary purpose of a re-interview? To assess disease comprehension, elicit partner information, verify adequate treatment, and refer for other supportive services. 2 is to provide testing, refer for other supportive services, provide risk reduction counseling, and investigate case clusters. Or 3, to gather additional partner locating information, follow up on partner notification status, elicit additional partners, and verify adequate treatment. To gather more info, I saw in the chat, exactly. Sometimes it's just to get the stuff you forgot or that didn't come up. Sometimes you can't cover everything. That's okay. That's what the re-interview's for. So for this one, our correct answer is number 3. Y'all are totally on the right track, killing it there in the chat. So while every effort should be made to obtain complete information during the initial interview, a re-interview may be necessary to gather more details or address unresolved issues after examination of partners or other sources. Now we have, what does the acronym OARS stand for? We talked about this. We have open-ended questions, affirmations, reflective listening, and summarizing. Observations, asymptomatic, reinfection, and symptoms. Outbreak, ask questions, re-interview, and stop the transmission. And OARS was one of our communication techniques, kind of our acronym to help us remember that. So we've got number 1, open-ended questions, affirmations, reflective listening, and summarizing. The acronym OARS is often used in training environments to help DI professionals remember the key communication skills. And with that, at 20 minutes past time, we did it. Thank you all so much for hanging in there and staying on the line with us. I'm going to stop sharing so I feel like I'm not in a black box anymore. This was super fun. It was kind of a lot of information. So again, I encourage you to go back and maybe read through the study guide for anything that I covered too quickly. And we will have our interactive study guide coming out very soon with little kind of activities and conversations and things. Yeah, we will see you next week is our field activities domain. That one's really fun. It's talking about going out in the field. So for folks who've only ever done telephonic work, this is going to be a really important one for you to kind of get that field skill set under your belt. And Kate DiBenedetto, who did our chapter for Field, will be there for that one. And yeah, thank you all so much. I'm sorry we went over. I kind of thought we might. And sorry about the polls. I don't know. We're just gonna wing it. I bet by domain 6 we get it. I don't know.
I don't know, maybe, but the chat worked well. Thank you
The
all for
chat's fine.
attending, and we look forward to seeing you next week.
Thanks, everyone.
Bye.